So welcome to this webinar. My name is Caroline Fichtenberg. I am a co-director at SIREN, the Social Interventions Research and Evaluation Network at UCSF, and I'm so happy to welcome you to this webinar where we are going to be discussing and unpacking the third Accountable Health Communities Evaluation Report. Before we get started, just a few housekeeping items. Want to give a big thanks to the Robert Wood Johnson Foundation, which is enabling us to host this webinar and to do many other of our activities. Second, this webinar is being recorded. The webinar is being recorded, and the presentation will be sent to all registrants and posted on our website as soon as it is available, which will probably be by tomorrow or Monday. Second, you have both a chat and a Q&A feature available to you. And we'd really like you to use the Q&A feature to ask your questions. That makes it a lot easier for us to be able to track them. And you can upvote questions if you want to, that kind of thing. We will make sure to have time at the end to answer your questions, but feel free to put them in as we go, as they come to you. So before we go too much further, I did want to make sure for folks who aren't familiar with SIREN to introduce us. So we're a research and dissemination center at the University of California, San Francisco, and we focus specifically on improving research on social and medical care integration. We do that by doing three things. We conduct research, we support researchers, and we synthesize and disseminate research. And you can see our website at the bottom there, as well as our email address. And we're on LinkedIn and Blue Sky. I want to highlight three things about our resources these days. For folks who aren't familiar with it, we have an evidence and resource library that is basically this searchable database of research and implementation about healthcare-based social risk interventions. We have over 3,800 items in that database, and you can search it so many different ways based on population or risk or type of intervention, etc. And so we highly recommend, if you're ever looking for any research or implementation tool in this space, to check out the SIREN Evidence and Resource Library. Second thing I want to highlight is we have a monthly newsletter where we list all the new research that has come out that month and all the new resources that have come out. So this is a great way to stay on top of what's happening in this space, in the research and evaluation space, as well as the implementation. We also highlight our events through that. And then finally, we have a podcast, and we have a number of episodes that are already up, and we're going to be putting new episodes up starting in June. So check that out as another way to be learning about what's happening in this space. Okay, to our topic today. We're going to be talking about the Accountable Health Communities Model Evaluation. And this the third evaluation report for this model, which came out in November of 2024. Everything that I present, I'm going to share a summary of this report, and everything that I'm sharing comes from this report, and you can find the report as well as a summary of the report on this CMS website, or by searching for AHC Model, CMMI, and you'll get to the AHC page on the CMS website. Following my presentation about the third evaluation report, we'll have a discussion with Dawn Alley, who is the head of scale at Impact Care, an organization that helps organizations develop their community health workforce. And also with Danielle Hessler-Jones, my colleague, who's a professor at UCSF and a co-director of SIREN. Before the panel, though, we wanted to give you an overview of the AHC model, as well as what the evaluation found, just to level set. So the Accountable Health Communities Model, this was a model or a test of an intervention that was funded by the Centers for Medicare and Medicaid Innovation at CMS. Its goal was to test whether navigation to community resources could reduce healthcare costs and or reduce avoidable healthcare utilization. And for those of you who don't know, it's kind of funny to present this in front of Dawn because Dawn was one of the lead architects of this model when she worked at CMMI. So Dawn, you can correct anything that I'm getting wrong. The model ran from May 2018 to April 2027 in terms of the intervention being delivered. 28 sites across the country participated for the whole duration, and I'll show you a map of those in a minute. And there were two slightly different versions of the intervention tested. In the assistance track, they were testing the impact of social risk navigation. And I'll say more about that in a minute. In the alignment track, they tested the impact of navigation plus community partner alignment. And I'll explain that also. And then finally, another thing I think that's a key thing about the model is that the model sites or the lead organizations, which were called bridge organizations, received funding to run the model. But none of that money could be used to pay for any of the services that were needed to help address the social needs. It just paid for screening and navigation, implementation, and other, data collection and implementation of the model. Here's a map of where the model ran. And you can see that in some cases, it covered a relatively large swath of geography. So at in Western Colorado here, or in Oklahoma. Is that the right state? I might have that wrong. Pardon me. Or in some cases, it was at the city level or partial city level. So the geographies varied, and it was spread across the country. So who was eligible to receive this intervention? There were Medicaid or Medicare beneficiaries in those geographies who self-reported at least 2 emergency department visits in the past 12 months, and who screened positive for at least one of food insecurity, housing instability, transportation challenges, utility difficulties, or interpersonal violence. And all of the sites use the same screening tool, which is called the AHC screening tool that many of you have probably heard of, and it's still in use in many places across the country. So how did the tracks work in terms of the service provision and the evaluation? So the assistance track, which happened in 10 sites, those individuals who are eligible were then randomized to either receive the intervention, which was the navigation, as well as a tailored list of resources that everybody got. That was just kind of the usual care. Or to receiving just the tailored list of resources. So in the assistance track, there was basically a randomized control trial comparing individuals who received navigation to individuals who didn't. And the navigation here was provided by individuals who after the fact, contacted the individuals who screened positive and talked with them about what resources were available, provided ongoing navigation as needed. In the alignment sites, and there were 18 of those sites, everybody who was eligible received the tailored list of resources plus the navigation. So in that case, there was no control group. And in the evaluation, the folks in the alignment group were compared to the control group in the assistance track. In addition to the alignment group, there was something called partner alignment. So these sites received extra money to help bring together different partners in the community on the clinical side, in social services, et cetera, to do an annual assessment of gaps in community resources and develop a QI plan to address those gaps. So the idea with the alignment is that by bringing together partners at the community level, maybe they would find ways to help address gaps in community resources, which would enhance the impact of the intervention. So those were the two models. So throughout the duration of this model, 1 million people were screened in total, which is a huge number. Among those, 18%, or about 200,000, were eligible for navigation. Among those who were eligible for navigation, 72% of them were Medicaid beneficiaries. 70% of them were working age adults. 56% of them were non-white, so Black or African American, Hispanic, or other races than white. 29% had less than high school education. 26% had 2 or more chronic health conditions. A little over half said that they were in poor or fair overall health. 46% said they had poor or fair quality of life. And over half had 2 or more health-related social needs. That's what HRSN stands for. So one of those 5 needs that were screened for. In terms of the prevalence of health-related social needs in those who are eligible for navigation, 2/3 of them reported food insecurity. Just over half of them reported worries about losing housing or issues with the quality of their housing or having no place to live. 44% of them reported transportation challenges, a little over 1/3 utility challenges, and a relatively small percentage, 5%, reported interpersonal violence. And again, over half of them had more than one of these at baseline. Okay, so in terms of needs resolution, first of all, out of the 200,000 that were eligible, about 136,000 ended up receiving the navigation because some of them didn't want it and some of them weren't able to be contacted. Among those, 40% at follow-up had at least one need resolved, and 28% had all needs resolved. In contrast, 30% couldn't be reached, and 30% had needs that weren't resolved for various reasons in terms of the follow-up. There were differences in navigation acceptance and need resolution. So individuals who were Black or Hispanic were more likely to accept navigation and have at least one need resolved. So were individuals with more than one social need and those who were duly eligible. Individuals with diabetes were more likely to accept navigation, but not more likely to have at least one need resolved. And those with less than high school education were also more likely to accept navigation, but not more likely to have at least one need resolved. Okay, turning now to the impacts of the model. First, for impacts on connection to resources and need resolution, I want to go over the methods that they used first. So this was based on a survey of those who were screened between April 2019 and March 2022. And the program ran, if you'll recall, from May 2018 to April 2023. So the survey was just a portion of the model participants. And the survey occurred 6 months after screening. They had a 25% response rate, and non-responders were different than responders. They were more likely to be older, more affluent, more rural, more likely to be Medicare beneficiaries, and they had fewer social needs. So to adjust for that, the survey data was weighted for differences between responders and non-responders, and then the results were also adjusted for a number of characteristics to make sure that the survey represented as well as possible all of the folks who were screened in that period of time. Here are the results for connection to resources, again, 6 months post-screening. This shows with the green bars the percentage of people who reported connecting to a resource for any need, for food needs, for utility needs, for transportation, and for housing. The numbers were too small for interpersonal safety to be included. And the green bars are for the assistance track, with the dark green bar being the intervention group in the assistance track, and the light green bar being the assistance track control group. And as you can see, looking at the 2 green bars, they are very similar across all of these categories of needs. And in fact, these differences, these small differences that you see, were not statistically significant. So they could have just arisen by chance. indicating that according to the survey data at least, the assistance navigation provided in the assistance track did not seem to have an impact on connection to resources. The blue bars are for the alignment track, with the dark blue again being the intervention group in the alignment track, and the light blue being the comparison group in the alignment track, which is basically a weighted measure based on the assistance track control group. And here again, you see the numbers are very similar, and none of the differences were statistically significant. Nor were there differences between the assistance track and the alignment track. So that's for connection to needs. For resolution of health-related social needs, this is the same kind of graph. So the green is for the assistance track, the blue is for the alignment track, and up top is all needs resolved, and then food, utilities, transportation, and housing. And as you can see first, one of the things that stands out is that the food was the least likely to be resolved. And there's suggestion that this might have been because food is something that you may address it 1 month, but if you don't have help again, it's likely to come back, food insecurity. So I think that's one of the reasons why that percentage is so low. And then the other thing is that, again, the small differences you've seen between the 2 green bars and the 2 blue bars were not statistically significant. So again, according to the survey, no impact of navigation on need resolution, either in the assistance or the alignment track. So the other thing that the evaluation looked at was impacts on healthcare costs and utilization of healthcare services. And the way that that was evaluated was different for the assistance and for the alignment track. And this is maybe going into too much detail for some of you, but some of you may be interested in this. So the assistance track, because it was randomized, they just looked at the differences between the intervention and control groups in regression adjusted post-screening values. So they just compared what was the utilization in the intervention group after screening and what was the utilization in the control group. And they adjusted those for slight differences between intervention and control groups and looked at that difference. In the alignment track, there was no randomization. So they compared the alignment track beneficiary data to data from the assistance control group. And then they did something called propensity score weighting and adjustment to make the assistance track control group as similar to the alignment track intervention group. And they used a difference in differences model. And here what they're doing is they're saying, what was the change in time for the alignment group? What was the change over time in the assistance control group? And what's the difference between the two? And in terms of the number of years post screening that was looked at, for Medicaid, it was 3 years, and for Medicare, it was 4 years. Okay, here are the assistance track results, and only the results that were statistically significant. And this shows that for total costs in both the fee-for-service Medicare and the Medicaid population in the assistance track, there was a 3 to 4% reduction in costs, or a reduction in 116 per beneficiary per month costs for Medicare, and a reduction of $54 per beneficiary per month for Medicaid. So pretty substantial, doesn't seem like a big percentage, but over the population adds up to substantial savings. The in utilization impacts, these are the 3 that were statistically significant. Medicaid saw a 4% reduction, or the Medicaid population in the assistance track saw a 4% reduction in inpatient admissions. That's 4 admissions per 1,000 beneficiaries per year. And then fee-for-service Medicare members saw reductions of 5% in ED visits, or 26 ED visits per 1,000 beneficiaries per year, and a 7% reduction in avoidable ED visits. So it's 18 avoidable ED visits per 1,000 beneficiaries per year. So those were the cost and utilization impacts in the assistance track. In the alignment track, the results were different. There were no impacts on costs. The differences were not statistically significant. And there were, and the main impacts were seen in the Medicaid population. There were no impacts seen in the fee-for-service Medicare population. The impacts in Medicaid were a 6% reduction in inpatient admissions, 7 admissions per 1,000 beneficiaries per year, a 4% reduction in ED visits, it's 34 ED visits per 1,000 beneficiaries per year, and a 4% reduction in avoidable ED visits, 14 avoidable ED visits per 1,000 beneficiaries per year. So impacts were seen only in Medicaid and only in utilization, not in costs for the alignment track. And the other thing is that the alignment and assistance track did not find statistically significant differences in the impacts, where there were impacts. Or so the alignment track didn't have statistically significant larger impacts, is what I mean. A few additional things. So they did do subgroup analyses looking at these impacts. So this is in the assistance track, and they found that individuals who had multiple HRSNs, who were a little over half of the assistance track intervention group, so this is showing the direction of the impact. So down means a reduction, up means an increase, and green means the expected direction of impact, and up means, red means the opposite direction of the impact you would expect or hope for. And individuals with more than one HRSN at baseline, had bigger impacts in terms of utilization. So they had a decrease in ED visits, while the beneficiaries with one HRSN had an increase. They had a decrease in avoidable ED visits and a decrease in inpatient admissions, both of which were increases for beneficiaries with just one HRSN. So in the assistance track, it looks like the intervention really works much better for beneficiaries with multiple HRSNs. And then in terms of subpopulations, with certain chronic conditions, they found that individuals with major depression, who were 25% of the assistance track sample, saw an increase in costs versus individuals without major depression, and saw differences, but they saw differences in utilization in the other direction. So they saw a decrease in avoidable ED visits and a decrease in inpatient admissions and unplanned readmissions, where the group without major depression either saw an increase for avoidable ED visits or saw no impact on these other things. So a little bit of a mixed picture in terms of the impact for beneficiaries with major depression, in terms of cost being worse for that group, but utilization seeing larger reductions. Here is something similar for the assistance track participants. And again, they saw differences compared to what they saw in the alignment track in terms of who seemed to benefit more. So here they saw that individuals with pulmonary disease both had lower expenditures and reduced utilization for ED visits and avoidable ED visits compared to beneficiaries without pulmonary disease. And then individuals with diabetes also saw a bigger impact than individuals without diabetes. Or actually, individuals without diabetes either saw increases in utilization or no impacts of the intervention versus decreases in cost and decreases in utilization for beneficiaries with diabetes. So this suggesting that, that the navigation in the alignment track, this is still assistance track, but Medicare fee-for-service, apologies. This is all the assistance track, but in Medicare fee-for-service, there was a bigger impact for individuals with pulmonary disease, and for beneficiaries with diabetes. So putting this all together, and believe me, there's so much more in the report as well, but just on these big top line findings, the navigation reduced costs and utilization in both Medicare and Medicaid populations, although the patterns with the alignment and the assistance track were slightly different, and the patterns in Medicare and Medicaid were also slightly different. Navigation did not reduce needs or connections to social services, according to the survey data. Alignment track did not have higher impacts, contrary to expectations. And navigation seemed to work better for some subgroups. Medicaid beneficiaries with more than one social need, Medicaid beneficiaries with depression, Medicare beneficiaries with pulmonary disease, and Medicaid beneficiaries with diabetes. Okay, that is it for the summary. And now we want to go into our discussion. So let me first see if there are any pressing questions. Okay, we'll get into these. Okay. One question I guess let's start off with just Dawn, with you, and then Danielle. What findings were most interesting to you?
For me, there's two big takeaways here. Actually, sorry, before I say that, I just have to say thank you. Thank you to SIREN for this conversation today. And thank you to everyone who tuned in. Especially, I see a number of the folks that really helped bring the Accountable Health Communities model to life on the attendance list. Some of the CMS team members who were original program officers, and some of the sites that did this really difficult work for 5 years through COVID. Just can't thank you enough. And I think that the findings here really demonstrate the incredible value that this intervention brought. And so for me, there's two big takeaways. The first is that this worked. This was a BFD. We're talking about, like, I want to zoom out because it's possible to get really down into all there's this 177-page report. We've got a lot of subgroups we can talk about. We've got a lot of mechanisms to dig into. But fundamentally, this model achieved a 3 to 4% reduction in total cost of care, which is remarkable. It was powered to detect a 1 to 2% reduction. And a lot of folks were like, you're never going to see that, thought that was really ambitious, and this blew that away. If you look, actually, some really nice Avalier analysis just came out about the CMMI portfolio, looking model by model. This model was the 4th biggest saver ever of all evaluations done by CMS of CMMI models. For those of my friends out there that think in more, per member per month kinds of numbers, the Medicaid beneficiaries in the assistance track, their spending was $54 lower per beneficiary per month than the control group. In Medicare, it was $116 lower. Like, these are, stop what you're doing and implement navigation individuals who have a combination of medical and social needs. There's a lot more work to be done here, but I think we can't actually say enough about, like, this worked. Why did it work? That's a much more complicated question. And I think a big thing that we learned is that it did not work in the way that we thought it would, which, here in 2025 actually feels painfully naive. But, like, if we back to, 2014, when this effort was originally being designed, I think we were thinking, we know that these resources pose barriers to health, and we want to see whether, if we can connect people with something that addresses their food insecurity or utilities needs, is that going to improve outcomes? even though we know from research, a lot of research done by the SIREN community, that once you start having these conversations about social determinants, it's not an A to B. Like, this is not a clinical checklist situation of like, okay, you have food insecurity, here's a resource I'm gonna, call and make sure you got there. That's not how this works, right? And what we saw was that, as Caroline nicely summarized, actually it worked despite the fact that connection rates to those social services weren't different across the groups, and needs resolution rates actually weren't different. And we can talk a lot more about why navigation worked. But I will briefly, and then I'll turn over so Danielle has a chance to weigh in as well, raise that I think we really saw here the effect of navigators. And in my work now, I do a lot of work to support evidence-based community health worker programs. And one of the findings that is really nicely detailed in the report qualitatively is, I would say, two things: the limitations of screen and refer approaches. So there's some notes in the report about, a beneficiary with diabetes who found the offerings at a local food pantry incompatible with their dietary restrictions. Somebody who said, well, yes, this helps me, this referral helped me cover the utility bills, but not the full, amount owed. So even when folks were making those connections to social services, it didn't really always, resolve the need. On the flip side, you saw these navigators in many cases using incredibly creative strategies to address needs that the beneficiaries raised that were not necessarily even on the AHC screening tool. So navigators working with clients to help develop budgets, helping someone get a driver's license so that they could get a birth certificate, so that they could qualify for benefits, providing appointment reminders to help people get to mental health appointments, all these sorts of things, which we're not in that narrow health-related social need definition. And so I think, again, my takeaway here is this worked, and it wasn't about individual needs and services. It was actually about seeing people as people and helping resolve the things that were most important to them.
Thank you, Dawn. That's helpful. And that answers one of the questions is popping up a lot in the Q&A, which is, how do you get these impacts on cost and utilization, but not impacts on needs and resolution? Danielle, do you want to add something about kind of what you feel like was most important to you or interesting to you in the report?
Thank you. I want to echo a +1 to everything that you just said, Dawn. Yes. I both in terms of the headline of there's a lot that worked here. There's a lot that worked. And before we get into the details of what didn't work, I just want us to take that moment of really reflecting on that. And then there's so much that we learned here. And so to the discussion of, well, why did we see these utilization and cost savings and not more modest or moderate impacts on resolution of HRSN and connections to social service resources? A few people have pointed out the SIREN social care model, and I just wanna lift that up because the AHC results as they were coming out were one of the things, along with some of the research that we've done, that has found the same pattern of results in our RCTs, saying that yes, connection to social service resources and resolution of health-related social needs is one pathway to seeing these health outcome improvements and utilization improvements, but we don't think they're the only pathway. And so there's a lot of work, as Dawn said, that's happening here that's not that really clear logic chain that maybe in our naive selves years ago thought was in place. People are whole people. We need to treat them as self. We need to recognize them. Navigators were doing a lot. Those examples, Dawn, that you gave are beautiful. I think there was so much going on in terms of building trust, building rapport, letting people feel seen, people feeling more likely to engage in terms of other services being linked with healthcare, as well as stress, feeling emotionally supported, which can address someone's overall stress and make them more likely to tackle this really, really tough and complicated healthcare system that we're living in the United States.
Okay, thank you. The other thoughts I have about this question about why there are these impacts on cost and utilization and not in the needs and connection, I really do wonder if two things. One, this needs resolution and connection was a survey that only surveyed one folks getting the intervention in part, in the middle of the intervention period, and had pretty low response rate. And so is it possible that the survey data somehow, sampled those who had the intervention and those in the control group differently? I don't know. That's a question. I think the other thing is the recurrence of needs. So it's possible that they got connected to a food bank and they had access to food for a month or two, and then something else happened, and they weren't able to use that resource anymore, or, et cetera. So I'm not, I feel like there's some possibility that there were needs, and I'm wondering if you guys think that there's some possibility that needs were actually improved, we just didn't capture it. And I'm thinking that especially because having done some of the interviews with navigators as part of the evaluation, I mean, the navigators just went so far and beyond, it seems like, to help the clients. Any thoughts on that? Or the last theory is that somehow there was contamination of the intervention into the control group. That, like, if someone screened positive, people really did not like the idea of not giving them that much of an intervention. And so somehow they got help, maybe not through the AHC navigator, but they got some other kind of navigation. Any thoughts about those ideas? And feel free to disagree and tell me that's not possible.
I think all those ideas are on the table. I mean, I think all those are possibilities. I'm thinking about that sampling, and I saw a question come through on the Q&A. Yes, it was a subsample of individuals who participated in that beneficiaries survey. And as you pointed out, Caroline, there were differences in terms of responders. And so and even with weighting, I think that there's a lot of potential impacts that could have on these findings. And so I do think we have to be keeping that in mind when we're making these interpretations. And then also yes, I mean, there could have been bleeding across the arms. And when we say controls, I just want to lift up that it wasn't that nothing was happening, right? It wasn't that you were screened and then said, all right, thanks. There were still a resource sheet provided. Some of these resource sheets, as you say, it could have potentially bled into conversations, highlighting potential social service agencies or connections, or it could have led to other conversations, other contacts in the community or within healthcare walls that this spurned on. Dawn, what do you think?
I totally agree. It's very hard to know some of these pieces, and this is a good opportunity, I think, to just plug. We can't learn everything we want to learn from the existing data, but I just want to hugely applaud CMS for making the data from the Accountable Health Communities model available for researchers to be able to link to claims and other data. I see some questions in the chat about different subgroups, and some of those were included in this evaluation report. But there is also an opportunity for folks to take a look at some of this themselves. I think, unfortunately, we don't have you. So, for example, in the impact model, we have a practice where in an ongoing way, sites are reaching out at the conclusion of CHW services to ask a subset of people about their experience systematically. And you could imagine that, or a variety of data capture that we could have done as part of AHC that would have allowed us to capture outcomes in a way that went beyond the survey, that we have here. So yes, like a ton of questions. I think, Carolyn, to your point about, kind of, it feels like the navigators must have moved the needle on the connections or the needs resolution. My gut here is that we were asking the questions, in part in the wrong way. If, for example, if the question is, you were referred to this resource, did you ever get there? Or did you ever access services from that resource? That is actually different than like, did you meet your goals? Was your situation improved, right? And, it may be that the navigator helped you with 5 things, but only one of them was the actual, need that is being, asked about that you initially screened positive for, or, it wasn't so much the referral to this food resource, but it was the help with your, thinking through grocery budget or whatever it is that, helped resolve. But like, again, trying to think about how do we still collect quantitative data that is going to tell us a meaningful answer for the healthcare system, but also broaden the aperture a little bit in terms of how we think about what constitutes, a successful intervention.
Thanks, Dawn. That makes a lot of sense. So there are a lot of questions in the chat about who were these navigators? Like, were they all CHWs? What were their qualifications? What were their education level, pay? I have to say, I haven't reviewed that part of the report as recently as I should have. Do either of you know an answer to that question? I know they weren't all CHWs. I know it was like a combination of kind of different kinds of roles at different sites. They did it differently, but do either of you know a little bit more about the navigators, how they were identified, what their qualifications were?
So what I can share here is that in the model design and the requirements for the sites, navigation was a verb. It was a service provided. And then the sites could decide who the nouns were going to be that delivered that navigation, whether that was a community health worker. In some cases, they relied on kind of health lead style volunteers. Often those sort of more voluntary models were harder to maintain over the 5-year period. And so I think there are some nice findings in the short answer is there's a lot of heterogeneity. There are some nice qualitative findings in the report about, for example, the sites that engaged CHWs, in particular, some qualitative data that, about how helpful it was to receive training on motivational interviewing and behavior change. And so the importance of shared lived experience. So again, that's qualitative. Like we can't definitively say that sites that employed community health workers produced better outcomes than other sites. But I think we do have some data, and I don't believe, I haven't seen anything that is about specifically like the CHW pay, but I think there is some good data that, or navigator pay, I'm sorry, I should say, but that sites that were able to, retain staff that had less turnover and that had provided staff with training on CHW core competencies were, on average, qualitatively, at least, that was associated with successful implementation.
Great, thank you. Let's see. What do you guys think about the subgroup results, where there are some populations that seem to benefit more than others? what are your thinking around those? And I can pull up the slide again if that's helpful.
I'm happy to start off and then send over to Dawn for more Dawn brilliance. Well, one of the things I think that stood out to me was findings around the number of health-related social needs, and overall where there were differences there, seeing more benefits among those community members that were reporting more needs at the start. And I just want to reflect a couple things. One is that is definitely in alignment with other literature that's out there that are, again, that our SIREN team and others have done, where we're consistently seeing that. And I think it makes logical sense too, that if you're entering a situation with more needs, there's more chances that navigator is going to be able to put you in contact with a resource, or to some way of addressing that need, whether it's directly or, as we've been talking about, through other means indirectly that add up and help with those needs. I also think, that there's some great findings out there to talk about how it's not as if each health-related social need exists in isolation, right? Again, we're whole people. And so we're living our lives, our daily lives are going through them, and these multiple pressures are working in conjunction with one another. And so I think that when you're coming to a meeting with a navigator and having multiple needs, all of that I think plays in and makes sense to me, that you may be benefiting more from this model. And that may have implications for some of you out there that have limited resources and are trying to figure out, how do I respond? Who do I work with first if I can't work with everyone? But that's one that I think spoke to me. The findings around chronic disease status, I think, are a little bit more mixed. We saw some highlights where, say, for instance, individuals with diabetes or COPD in some ways, with some insurance status, benefited more versus benefited less. And so I think that those findings for me were not as clear cut. And I think that is just a really, really great area for future work. So things that came up for me were thinking about, where we're seeing greater benefits or not as much benefits for a group. Does this have to do with the insurance offerings? Does this have to do, for instance, with how likely someone was already being offered these same resources, or who had received navigation in the past versus had never been approached? Was it differences on some other basis? So that's my long way of saying I'm really, really interested in unpacking more in the future the chronic disease condition, mixed results. What about you, Dawn?
So I'm of two minds here. I think that it is important that in general, these findings were, there's a lot of complexity in these subgroups, but in general, the findings were stronger in people who had chronic conditions. And I think that's important as we think about how to, in particular, target interventions. There's a lot of emphasis right now on things like kind of universal screening for health-related social needs. I think that can be a little bit of a double-edged sword, because it relies on people to come into a clinical site, get screened, participate in the screening, which we know a lot of people that might benefit from these services aren't doing. And so I think one question raised by this is, should we just be thinking about a model where, for example, navigators or CHWs are doing proactive outreach to people with select chronic conditions in, low-income zip codes, just as an example? Like, how much do we, there's a real opportunity to think about where we could get the biggest effect of these services. I also think it's really remarkable It's a little hard from the way the results are presented in this evaluation to kind of calculate the per member cost of the intervention. But each of the assistant track sites only received $2.5 million over 5 years. And they served a lot of people with that. I think like some back of the envelope math, we're talking about something that's only along the lines of like $300 per person. We saw effects in people with significant chronic conditions. And so on the one hand, there's a part of me that says, like, let's use this and really think about data-driven approaches. On another hand, there's a part of me that says, like, let's not try to gild the lily too much here, or, get down into subgroup analyses that we start to feel a little unsure about. Someone raised the question in the chat about, for folks with depression, like, how could it be that utilization in every category went down, but costs went up? Like, there's some stuff in here that I don't totally know how to interpret when we get down into these smaller subgroups. But overall, again, I think we have a very strong signal that this relatively inexpensive intervention worked profoundly well in populations with, pretty significant, in many cases, chronic conditions and multiple health-related social needs.
Great, thank you. I want to highlight one of the questions asked was like, it'd be really great to get more information about these navigators, to have a paper on that. So I want to highlight that there's a lot in the report. Maybe we'll do a second webinar where we highlight more of like the lessons learned in the implementation, because there is a lot in the report about that. And there also are some other kind of like short pieces that were produced throughout time. And I don't think I can chat to everybody, unfortunately, but if you look up AHC CMMI, you'll come to the AHC model page. And if you scroll down, you'll see all these links to the reports and then to all these other issue briefs highlighting lessons learned. So would highly recommend looking at that. I think one interesting question that somebody had was, how might we use these results in commenting on the work that CMMI is doing around, I'm sorry, not CMI, CMS currently has an open comment period to comment on measures and removal of the social risk screening quality measures. Any thoughts about how you see these results relating to that?
I love this question, so thank you to this person. And I don't want to volunteer SIREN, and I have no idea whether this is in scope, but I think it would be incredibly cool if there were an opportunity for someone to sort of package some of this research in a way that folks could then take and, plug into and leverage for everybody who's submitting relevant comments. I think that, to my mind, one of the findings here is that we shouldn't necessarily stick these kinds of interventions in the SDOH box. That the navigators were doing more than addressing only these needs. This is an opportunity to improve value, to improve quality and reduce costs. And so, we can think about it from that lens versus thinking of it as, an SDOH or health equity intervention. I would also note that, this is a great time to comment on quality measures, both what CMS is proposing around changes and removal, and like what we think we should see instead. I am really obsessed with some of the person-centered care planning measures that are around our people achieving their goals, which again is a different way of thinking about this. Not sort of what was the need I had addressed, but, did I achieve whatever my goal was, whether it was clinical or health behavior or social? I think that In the past, there's been an emphasis at times on different measures of activation and self-efficacy. Like there's a whole world of measures that we might think of out there. I don't know exactly what the right ones are, but I do think we have an opportunity to say, based on what we know of the evidence, what is the best way that we think we could be using measures to drive improvements in care now.
And with just 3 minutes left, let's transition in these comments, Danielle, to just any kind of recommendations you feel like you have. For example, we talked a lot about implementation recommendations. We haven't talked a lot about research recommendations. I don't know if you have something to say about that.
Thanks so much. Well, first, I do want to give a quick plug for the data being publicly available. So this is a huge data set. And while it's here, while we have the opportunity, I highly encourage folks going online, requesting that data, downloading it, and continuing as you're able to explore some of these great questions, because no one or two or even 3 reports is gonna get the job done, right? And then I think there's so many unanswered questions, so many opportunities here, I think, putting my researcher hat on. So as a lot of folks brought up in the Q&A, there are a lot of interesting subgroup analyses here to understand who is the model working for, who it isn't working for. And on my mind is really thinking and about where the model isn't working as much, what do we need? Is this a different model? Is this that, it's really about the lack of social services out there and needing to strengthen and properly fund those services? And then last, I want to highlight the focus on mechanisms. So as we started out in our discussion, talking about how, well, gosh, if this isn't the only pathway of connecting individuals with services and resolving their health-related social needs, let's properly assess and measure and examine what are the other pathways. So some of you noted in the Q&A, wow, did we measure these other things? Well, yes and no, a little bit in the qualitative data, but not really enough a priori in the design of this large demonstration project to look at those other pathways. So that's really what's on my mind for the future. And thank you so much again for joining us and giving us the chance to talk about it today.
Yeah. 1 minute left, Don. Any final thoughts?
Laura asked a great question, which is, hey, I thought when CMMI models were successful that they were supposed to be expanded. And I think this is a place where it would be great for people to be thinking and writing and advocating about what does expansion of this work look like. I think to date, CMS has thought that requiring or incentivizing the screening sort of to a certain extent constitutes expansion of AHC. But actually, I know for us, when we were thinking about AHC, it was almost a worst case scenario to like do screening with nothing else. And I think we are seeing a lot of that, unfortunately, right now is, hospital screening, and then there's not a requirement around what they do about it. So I think it's important to continue to advocate for those solutions and opportunities at the state level as well.
Fabulous. Well, I am so sorry to have to bring this to a close because there were a lot of other questions we didn't get to. But thank you so much, Don and Danielle, for participating in this. And thanks all of you to joining us. And join our newsletter or sign up for our newsletter, follow us on social media to be informed about future events like this and more research in this space. All right, thanks everybody and have a great day.
Thank you.